So these are SMLE questions, so they're not the perfect written, but it's basically we want to get the information out of all these MCQs. So this question: for assessment of pulmonary metastatic disease, indication for thoracentesis: A, glucose less than 60, pH more than 7.2, polymorph more than 90%. What do you think, guys? So for malignant pleural effusion, 5% of malignant pleural effusion patients suffer from pleural effusion, and dyspnea is the most common presenting symptoms, and they usually fear of downing to death. Why here in this question we chose this 90% polymorphs? Because it's really indicating, because you want to rule out infection on this patient. So for the pleural fluid analysis, the light criteria has little diagnostic value for malignant pleural effusion. For malignant pleural effusion, usually low glucose, less than 60, low pH, less than 7.2, and a high pleural fluid amylase is commonly caused by neoplasm. ADA is used for differentiating TP from, but on this questions, the glucose less be pH effusion, but polymorph more than 90%, well, indicating maybe there is an infection and you want to rule it out. So let's go through just the pleural fluid analysis. As you know from the lights criteria, either you have to differentiate it whether it's oxidative or transudative. So exudative pleural effusion would be either more than 2/3 of upper limit normal of LDH, or if you have the LDH fluid to LDH serum more than 6.6, or the protein fluid to protein serum more than 0.5, the ratio. So these are indicating exudative. And also if your pH is less than 7.2, or glucose less than 60, or protein more than and most of it is the really indicated exudative. And these stains you can use to further diagnose the gram stain or results to the TB or they come in the exam and highlight amylase in DNC or esophageal cholesterol in pleural condition sedate can cause high cholesterol culture. If there is a fluid to 5 this fine interferosis and high proPNB, that's heart failure, pH less than 7.2, either parapneumotic effusion, indication for thoracentesis: A, pH more than 7, glucose 60, loculated pleural effusion. They're not greatly written, but the indication calculated effusion indication actually you're ruling out empyema. So the radiological fluid looking or positive pleural fluid, or if there is a pleural fluid pH less than 7.2 or a glucose less than 60. These are the indication for thoracentesis. It's likely indicated most of the patient, especially when there is more than 1 centimeter lying on the lateral decubitus. That's meaning that there is in the fluids, and probably you need a tap. But you don't need a tap for congestive heart failure. No need to do thoracentesis with patients with obvious. May need to have further study. Just like a heart failure, we usually increase the diuretics, and that should take care of the pleural effusion. Otherwise, if it's massive, you could do thoracentesis for that. So in heart failure, febrile pleuritic pain, unilateral, no cardiomegaly, no response to diuresis, then you would do that thoracentesis. Patient coughing blood with the pleural effusion that has high protein, low glucose, and a high LDH, and a high lymphocytes. What's your diagnosis? Oxidative due to malignancy, exudative due to heart failure, transudative due to malignancy. So he has like high protein, low glucose, high LDH, and high lymphocytes, all indicative of exudative, not transudative, exudate. And there is no exudative on a heart failure. So most likely due to malignancy. Okay, patient with the bronchogenic cancer has recurrent pleural effusion and did multiple thoracentesis. What should be added to the management? A, diuretics, C, thoracotomy, D, low resistant bleeding at rate more than 7 ml per kg per hour, or there is increasing hemothorax seen on the chest x-ray, or if the patients remain hypotensive despite adequate blood replacement, or other sites of blood loss have been ruled out, or patient decompensates after initial response to resuscitation. Same for the thoracostomy that I just mentioned. Patient with pleurisy, silent thoracentesis at mid-axillary line between what? 5th, 6th, or 8th. 5th intercostal, like between 5th and 6th, or between 6th and 7th, or between 8th and 10th. Let's see some answer here, guys. You guys can chat. You just can chat and write what's your answer. It would be better if it's interactive, to stick more in your mind if you think about it a little bit. Perfect. Okay, so I can went through this one because it's it's a good questions at the end of it, and it comes in the other exams. This is from one of the exam books actually. Really, it's the same question. So this is the caveat here. If you had mid-clavicular, this case was along the mid-axillary line. This one, they ask about mid-axillary line. So if you're going to use mid, you would go 8th and 10th rib. So in the 9th intercostal space, if it's a mid-axillary line. And if it's like a mid-clavicular line, be with the rib. For the paravertebral line, 10th and 12th ribs. Here is much more maybe clear for you guys. So basically either mid-clavicular line here, So in the mid-clavicle line, you would choose the 7th intercostal space. So between 8th and between, if you go mid-clavicle line. If you would go, no, you would go a mid-axillary line. The mid-axillary line, you would go with the 8th and 10th reps, so meaning the 9th intercostal space. When you use paravertebral line, like at the back, you would do your thoracentesis, you would go lower. So 10th and the 12th reps and the 10th intercostal space. So for this question would be, your answer would be, because it's the mid-axillary line. So if it's a mid-axillary line, it's going to be 8th and 10th. That's your side. And just to above the rib, not below the rib, above the rib, because you don't want to injure the blood vessels or the nerves there. So you go above the rib. Okay, elderly smoker with progressive shortness of breath on chest X-ray, massive right pleural effusion. What's your next step?
A.
So indication for thoracentesis, we just mentioned it. So they're the MAGE. Because it's a massive pleural effusion, you would relieve that effusion with thoracentesis. Patient developed a spontaneous pneumothorax, result after 2 weeks without intervention. What to advise him so it won't recur again? A, not to go on an airplane for 1 year. B, not to play a football for 1 year. C, not to go in 4 weeks.
C.
Any thoughts? So not to go on airplane for 2 weeks. So air travel should be delayed at least 2 weeks after uncomplicated chest surgery and a confirmation of resolution of any pneumothorax, or collected air by chest radiograph is recommended. Careful medical assessment is required before travel, just to prevent recurrence of the pneumothorax. If they got within the 2 weeks in the airplane, they can have recurrence of the pneumothorax. Patient with non-ACTH dependent Cushing for adrenalectomy. What is the post-operative management? Post-operative fludrocortisone, post-operative methadone, I think methadone, I don't know that one. Preoperative hydrocortisone, preoperative alpha blocker.
You have to have a preoperative hydrocortisone, but
Yeah. So
post-operative.
adrenalectomy, you want to do preoperative before they go to surgery. You want to do hydrocortisone before they go to the surgery. Otherwise, and the adrenal crisis. So to avoid adrenal crisis, you would prescribe steroids therapy given 1 week before the surgery. Patient with the typical cushingoid features, low ACTH level. She's taking topical steroids for her cirrhosis. What's your management? No further testing. This is iatrogenic Cushing, abdominal CT scan, brain MRI.
Maybe A.
B. It will be abdominal CT.
Also, the most common cause for Cushing syndrome is prolonged exogenous administration of glucocorticoid hormone. And actually, even if it's topical, like just a cream, but it has like high potency creams, you could have like a iatrogenic Cushing from only the cream. Adverse effects for typical corticosteroids This can acneiform eruption, atrophy. It can cause all these side effects. It can cause also iatrogenic Cushing's syndrome by only local and hypotensive local corticosteroids. So you keep in your mind. Asymptomatic patients with hemochromatosis with high ferritin level. What to do? Check ferritin after 6 months, upper GI endoscopy, repeated phlebotomy. Any thought? They should mention the level. I think the level is very important there, but here is not mentioned, just high ferritin. So for those patients, you really do repeated phlebotomy for them. Hemochromatosis, usually ferritin elevation is not specific. The transfer saturation is less than 5%, but both ferritin, CRP are elevated, repeated iron study in 1 and 2 months. You just want to make sure that this is really hemochromatosis. So the high ferritin level is not due to iron overload. From this slide, I just want you to remember by figures 500. When it's less than 500, you see more than 500 ferritin level, then you have to do phlebotomy and make sure that it's less than 500, like in the 400 range. Why? Because you want to prevent the deposition of the iron and on the organs.
Less than 500?
Less than 500. You want to keep it less than 500. That's from up to date. So you want to keep it less than 500. So probably that number in the exam would be 500 in the range and above. But less than 500, you're okay. There is no complication. But when it's 500 and more, yes, you want to do phlebotomy, repeated phlebotomy until you get the level under the 500.
Okay.
Patient with diabetes and takes steroids for asthma. After surgery, admitted to ICU. Lab showed glucose low, other labs all normal. Reason for admission. It's not well written, but it's like a patient takes steroids for asthma and he was admitted after surgery in ICU. It's going to be like all those patients with the steroids, on steroids, they usually, when they get sick or they have surgery, they need a stress dose of steroids. You need to double up their steroids level. Like you want to give them a stress dose of steroids. So for example, a patient who was in 5 milligrams of prednisone every day, you want to stress dose them. So you put them like double it, 10. But usually if they go in a surgery, we usually will go with the IV hydrocortisone. And we give like a 50 Q8 hours. $100 milligram Q8, the low glucose, I think, from the adrenal insufficiency. And if we look at what happened like in the adrenal insufficiency, like lab results usually, because it mentions all the labs it's normal. I don't think so. When you have some adrenal insufficiency, the first things in your lab is hyperkalemia. It's okay to 92%. And then decrease sodium and potassium ratio is 91%. You're going to find some sodium potassium disturbance there, like hyponatremia and hyperkalemia. And you would have like it could be hypercalcemia, but I don't think that it's rare. So hypoglycemia here, they put it as 20. But we see it more frequently, hypoglycemia on adrenal crisis. So just paying attention for those people on steroids when they go to surgery or when they admitted to inpatients or they have infection or they have, for any reason, they went to the hospital. You have to stress them. So you have to give double of that steroid they were on. Okay? Patient did gram patch of a gastric preparation. Then he had esophageal bleeding. What is your next appropriate step in the management? Would do endoscopy, laparotomy, or CT scan?
CT scan.
You would do a CT, okay. Let's see here. So you would do actually endoscopy here. So if you have a peptic ulcer disease, let's see that you have a gastrointestinal complication, like this patient that had a perforation, surgery for perforation. They did the gram patch, and they would do either endoscopic colon dilatation for structural surgery for obstruction. I think you would be more beneficial from doing endoscopy, at least because this patient here then he has esophageal bleeding. Regardless, if you have just esophageal bleeding, you want to do a scope. Right on, you want to do a scope. So just I looked at the gram batch complication, and they usually leakage or post-operative bleeding, post-operative ileus, or he would have an infection or intra-abdominal abscess, pneumonia, and other complication. But if you have esophageal bleeding, you would do endoscopy. Most accurate test for esophageal dysfunction. So if you have esophageal dysfunction, you would do endoscopy, barium swallow, CT with contrast, or you would do esophageal manometry.
I think the manometry.
Okay, so the esophageal manometry indication. So if you have a primary esophageal motility disorder like achalasia, not esophageal spasm, or hyper, or you have non-secondary esophageal motility disorder like scleroderma, diabetes, and chronic idiopathic interstitial obstruction. Patient underwent esophageal dilatation. After 12 hours, gastrography showed leak, temperature was high, hypertensive. What's your manage?
Stent.
Yes.
Okay, so let's go back. Like a potential leak. What to do? Surgical drainage for that. And these are the complications for the resuscitation. Could have a perforation, could have a chest pain, bleeding, nausea, and respiratory problem. Patient with early satiety with a 10% weight loss in 8 months, hemoglobin 8.5, low MCV. What to do? Empirically, H. pylori eradication treatment or gastroscopy?
Gastroscopy.
Okay, good. Because this is a red flag here. Red flags, just remember these red flags. Any one of these red flags with a patient with dyspepsia, you're going to do endoscopy. So anemia, weight loss, anorexia, recent onset or progressive of that dyspepsia, melena, hematemesis, swallowing difficulty. Or if the patient more than 55 or they have any alarm symptoms, you would do upper GI endoscopy for any dyspepsia. Okay, patients with hypertension, cold extremities, radial pulse more than femoral pulse. Case of coarctation of aorta, what's your next step? CT or chest X-ray?
CT.
They teach us always almost this figure 3 for, they want us to do the easy one, the chest X-ray first, because you can see that sign and you would diagnose the coarctation of aorta. So you just like remember the figure 3 for the coarctation of aorta. So coarctation of aorta, Well, you can guys read about it, but it's X-ray. You would do chest X-ray. Chest X-ray first, then you would do your probably ECG, would show maybe right ventricular hypertrophy, left ventricular hypertrophy, or echocardiogram would be your diagnostic method. Patient with coarctation of aorta, radiofemoral pulse delay. What's the confirmatory test here? Echo, chest X-ray, CT angiogram.
From previous, he said echo for confirmation and chest X-ray for diagnosis.
Perfect. Okay, so you want to confirm that one. So you would do echocardiogram. So the diagnosis of coarctation of aorta is usually confirmed by transthoracic echocardiography. This is from UpToDate, guys. In adolescents, adults, and some pediatric cases, cardiovascular magnetic resonance imaging, CMR, or CT are used as a complementary diagnostic tool. So, but you confirm with the echocardiogram. Oral frontal involuntary movement. It is catatonic phenomena, tic dyskinesia, Parkinson's. The question is not the greatest. When there is oral, frontal, it's like kind of, they are describing dyskinesia, tardive dyskinesia. I don't know how they combine it together, the tic and the dyskinesia, because they're two different things. I'm going to go through it here. So tardive dyskinesia is involuntary, repetitive, non-goal directed movements. It's like in the face, you would like chewing and moving aside the face. So we call it orobuccal lingual, or a neck or extremities, even in the trunk can be. Typical tongue thrusting, lip smacking, lip pursing, grimacing, all these like يعبس اللي يحرك شفايف وكذا يعني involuntary. He's just like he cannot control it. So this is tardive dyskinesia. But tic is a sudden recurrent movement, like a movement in the cheek, and it's like they moving their face like quickly, twitching like that's what the tic is. It's like twitching on the face. So a 65 years old with a DVT, which of the following factor indicate thrombophilia assessment?
C.
Perfect, C. So these are the this slide from New England Journal of Medicine, it's very nice to remember. What is the clinical characteristics suggestive of inherited thrombophilia? Like, when do you suspect that there is inherited thrombophilia? You would say this patient, we have a blood test. So if the thrombosis at young age, so anybody with less than age 50, you would think that they may have a thrombophilia, especially if there is like a weak provoking factors, like minor surgery in combination with oral contraceptive pills or immobility, or unprovoked venous thromboembolism. So you would do that for the young people. You would do thrombophilia workup, or if they have a strong family history, like first degree involved, like had a DVT. Or if they have a recurrent venous thromboembolism in the past at a younger age, or if they have venous thromboembolism in an unusual site, like a splanchnic or cerebral veins, all those are indication for the thrombophilia workup. Next one, we're going to mention the other ones, which is the acquired. because they mention it here down here. Antiphospholipid must be considered antiphospholipid syndrome, but it's not inherited. Pain, venous thromboembolism should be assessed for myeloproliferative neoplasm or paroxysmal nocturnal hemoglobinuria. The acquired thrombophilia, the antiphospholipid syndrome, and hyperhomocystinemia. The commons, then we should not forget about the inflammatory bowel disease, very important, and the cancer, nephrotic syndrome, myeloproliferative disorder, pregnancy, oral contraceptive pills, or hyperviscosity. All those can cause thrombophilia. Lady present to your clinic after cardiac events. Which is true about the condition?
I think A.
A, antiplatelet used for a short duration prevent ischemic disease, or calcium channel blocker is indicated indefinitely in patients with ischemic heart disease, estrogen replacement therapy in postmenopausal women, prevent ischemia, or ACE inhibitor are indicated indefinitely for heart failure. See this question, guys. I know all my colleagues, previous professors, previous consultant doctors, they answer A. I disagree, totally, I disagree with it. You don't use aspirin for short duration. That article, the circulation article you guys provided to us, just carry on and read the comment. They highlight only the short duration. That's good, I know it's good, but you carry on indefinitely. Guys, you carry on indefinitely for aspirin therapy. That's not the right answer, because I'll explain that circulation. Just go to the article on the circulation and read it all. Read all the comment, like the conclusion. The conclusion is about like a 1 page, maybe 1 page, full 1 page, just conclusion. And the first of all, they said using aspirin for short duration. It's good to decrease the mortality of the patients, morbidity for them, but you have to carry on indefinitely for that. Me, I chose all my answers. I chose ACE. Why I chose ACE? Because if he has heart failure, you want all patients with symptomatic heart failure, those in the functional class 1, significantly reduced LV function, should receive ACE inhibitor unless contraindicator. So if there is a heart failure, like LV dysfunction, you would use ACE inhibitor. That's a correct statement, guys. So I don't agree with the short aspirin therapy as a correct answer for the question. So elderly with GERD, not respond to BBI. What's your next step? Manometry, 24-hour pH monitoring.
pH monitoring.
pH monitoring.
Yeah, so for the 24 hours pH monitoring for gastroesophageal reflux disease, you want to evaluate if they have alarm symptoms, but this patient was not responding. So the second main indication for the 24-hour pH monitoring is assessment for atypical symptoms such as cough, hoarseness, or voice or sore throat, or atypical chest pain or an asthma, usually following a failed or incomplete response to the therapeutic trial of the double dose PPI. Pathology of rapidly progressive glomerulonephritis, IgA deposition, cellular crescent, dilated tubular outflow. So which is the pathology that you're going to see?
A.
But this is rapid progressive glomerulonephritis, rapid progressive glomerulonephritis.
That will be C.
I don't know.
C. Dilated tubular outflow.
No, you should know this one by heart, guys. like really by heart. When you see rapid progressive glomerulonephritis, that's cellular crescent. Pathognomonic, rapidly progressive, centric glomerulonephritis is a syndrome associated with severe glomerular injury, but does not donate a specific etiology for glomerulonephritis. Characterized by rapid and progressive loss of renal function associated with severe oliguria and signs of nephritic syndrome. So cellular crescent goes with the rapid progressive glomerulonephritis, and they call it crescentic glomerulonephritis. Patient with a thyroid mass, 2.2 in the left side, just below the angle of the mandible. Did FNA reveal follicular thyroid? Follicular thyroid carcinoma. What is your diagnosis? Ectopic thyroid, apparent thyroid, metastatic thyroid, thyroid plus CL test. It's not well structured, this question.
Metastatic.
Yeah, so it's a follicular thyroid carcinoma is the second most common cancer of the thyroid after the papillary carcinoma. Follicular and papillary thyroid cancers are considered to be differentiated thyroid cancer. Together, they make up to 95% of the thyroid cancer cases. Lady with 2 years history of frontal sinus area headache. The headache usually lasts between 12 to 24 hours. This time, the headache is associated with nausea and is continuous. She takes over the counter decongestant and analgesic, but it does not relieve the pain. There is no papilledema. What are you going to do? A, CT scan of the sinuses. B, brain MRI. C, more history and physical examination.
C, more history and physical examination.
Perfect, yeah. So you want to go for more history and physical examination. But these are the red flags for headaches. So if you have any systemic symptoms like fever, weight loss, or secondary risk factors like if the patient's HIV or has systemic cancer, those are red flags. If they have neurological symptoms or abnormal signs like confusion, impaired consciousness, or if the onset is sudden, abrupt, or progressively worsening, or there is in all patients age more than 50, and previous headache history, first headache, or different, like a change in attack frequency, severity, or clinical feature, like this patient. Or if there is like a triggered headache, like they do Valsalva, they get the headache, or they exert themselves, they get the headache, or they cough, they get the headache. So that's a red flag too. Young female with thyroid nodule. T6 is low and T4 is high. FNA was inadequate. Next, you would do FNA or thyroid scan.
Beta
Okay, so the indication for the thyroid scan, there is a thyroid nodules, diffuse or multinodular goiter, clinical hyper or hypothyroidism, evaluation of substance mass, ectopic thyroid tissue, subacute thyroiditis at the early phase, or patient with a previous history of like a tumor on there. You would do that thyroid scan. Female with family history of Crohn's, but symptoms of ulcerative colitis, rectal pain, and bloody diarrhea. What is the next established diagnosis? Like if you think that this is ulcerative colitis, Yeah, this is Crohn's disease, but the symptoms kind of suggestive of ulcerative colitis. What next to establish the diagnosis? Upper endoscopy, fecal calprotectin, anorectal manometry.
B.
A.
B.
Yeah, it's one of the tests that would actually help you when like disease, I tell you that there is organic disease, the high fecal calprotectin. So you would have either like you would have the CRP, the fecal calprotectin, the histology would help you with the colonoscopy to differentiate the two. But fecal calprotectin would help you to see that there is organic disease along. 30 years old female, not pregnant, present with fever, flank pain, urine culture shows 50,000 E. coli. What's the appropriate empiric antibiotic? Piperacillin tazobactam, B, nitrofurantoin, C, ceftriaxone. Basically bionephritis because they have fever and flank pain with the positive culture.
B. Nitrofurantoin.
Nitrofurantoin. When you have these kind of patients, you want to go aggressive actually because it's a bionephritis. So when you have a bionephritis, so you initial therapy. This is from American College of Family Physician site. The initial antibiotic use, if you have a resistance in your country, don't use Cipro and Lethal. You go so ceftriaxone. You could use the imipenem, or you could use the aminoglycosides. But these are the initial steps for treating bionephritis. Then you step down when they discharge or when they're stable, either with Cipro, Levo, trimethoprim, Bactrim, all the nitrofurantoin. But at the beginning, when you have bionephritis, you would use intravenous and you would go aggressive. Female with high calcium, low phosphorus, vitamin D also level. What's your diagnosis? Primary hyperparathyroidism or secondary hyperparathyroidism?
Primary. It's a primary.
Okay, so primary. So when you got primary hyperparathyroidism, you'd have high calcium, high parathyroid hormone or normal, and the increase in vitamin D, and in the phosphate would be low. Secondary, calcium would be low, parathyroid hormone would be up, and the vitamin D would be low, phosphate would be up or high. And the tertiary here, high calcium, high parathyroid hormone, low vitamin D, and high phosphates. Lady with obesity and type 1, type 2 diabetes mellitus, what's your advice about diet beside the exercise? A, low-fat diet decrease 5 to 10% of the weight. Low glucose index diet lowers the weight 5 to 10%. Low carbohydrates more effective than low-fat diet.
C.
C.
Low carbohydrate more effective than low-fat diet. Well, you can look it up. It's the low glucose index lowers the weight 5 to 10%. And it was good, this one, slides. This was from an article that I looked up. These comparing like which one is the most effective for reduction of the weight. So if you use like low energy diets, like 800 kilocalorie, for example, you would lose 7 to 13 kilos. And if you have the very low energy diet, 400 only kilocalories, in 2 weeks you lose 5 kg. The high protein diet, in 12 weeks you would lose maybe 5 kg. The low fat diet, you would lose 5 kg. So it's like the most influence when the low glucose index lowers the weight 5 to 10%. That was the correct answer. 44 years old male, married for 3 years, complaining of decreased libido, painful tender breast, and bilateral breast milk can be expressed manually. He came for evaluation. He complained of His physical examination is otherwise unremarkable. Prolactin level was very high. What investigation for high prolactin level and galactorrhea?
Okay.
A.
brain.
Yeah,
Secluded keratinoma.
yeah, to rule out pituitary microprolactinoma. And these are the clinical presentation for the hyperprolactinemia. Female patients with galactorrhea and high prolactin level. What's your management? Surgery or cabergoline?
B. Cabergoline.
Yeah. So these are the medical therapies option for management of hyperprolactinemia. Either you can use the dopamine agonist, or you can use the what we use now. Actually, we don't use bromocriptine because it's like kind of the old-fashioned. The cabergoline we used actually it's like both are good, but we tend to use cabergoline has greater affinity and selectivity for pituitary dopamine and a longer duration of action. That is indicated in the case of bromocriptine resistant or intolerance. So if there is like cabergoline and bromocriptine, you would use bromocriptine first, unless they mention here these indication. In the case of when you would use cabergoline. And the indication for when do you do surgery for hyperprolactinemia is indicated if the case is resistant to the medical therapy, or considering patients with the intracellular tumor for whom long-term drug treatment is not acceptable. And the surgical decompression may be required for tumor pressing on the optic chiasm, so they have the visual symptoms, or surgery should be avoided in case of the extracellular, like without optic chiasm compression, expanding tumor because of the low success rate. So they do very well on the medical treatment if they are extracellular. Patient with cushingoid feature. I think that's my last slide because I didn't do the lots of but I have the answer here. Pushing and a high urinary cortisol level. What to do? CT head or CT abdomen?
CT abdomen.
You would rule out adrenal. You would use to rule out adrenal adenoma causing that. I think those are the slides that I prepare. The other ones I didn't prepare actually. That's all, folks, for today. I'll try to prepare more for you, inshallah, from the SMLE and get you enrolling. Do you have in particular anything, guys, any suggestion? Or we're good with doing the like this, like presenting the question and
Good. Thank you very much.
any suggestion, guys?
It's a perfect method that you did here. Thank you very much for your help.
Yeah,
we
sure.
Appreciate it so much.
Yeah. I have I have I have this opportunity and actually want to contribute with you guys in trying to get you the highest mark in medicine, inshallah. So I do have previous one, but we'll give it like every day, like 40 minutes to 50 minutes talk. I think you would absorb more. So, but just try to the different ones, challenging questions. I'll go over them all. Like pretty much. We have a lot of these. Okay.